Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 518 of our pharmacotherapy series, which majors in chronic kidney disease. The first case reads, PJM is a 42-year-old white man who presents to the clinic with a 1-month history of cough, nasal congestion, facial pain with headache, fever, and lethargy. During the past week, he has noted bright red blood in his phlegm, which has worsened in the past 3 days. Pertinent laboratory values are as follows. Serum sodium levels of 143 milliequivalents per liter. Serum potassium levels of 5.1 milliequivalents per liter. Serum chloride levels of 102 milliequivalents per liter. Bicarbonate content of 24 milliequivalents per liter. A serum creatinine of 2.8 mg per deciliter. ABUN of 41 mg per deciliter. This compares with last year's physical checkup visit when his serum creatinine and BUN were within the normal range. Hematologic studies reveal a hematocrit of 35%, a hemoglobin of 11.7 grams per deciliter, a mean corpuscular volume of 69 microliters, a mean corpuscular hemoglobin concentration of 24%, and a reticulocyte count of 1.8%. RBC indices are normal, and the platelet count is 175,000 per microliter. His 24-hour urine contains 3.8 grams of albumin. The normal value is less than 30 milligrams, and his eGFR is calculated to be 27 milliliters per minute per 1.73 meters squared. His urine also contains many RBC casts and 16 RBCs per high power field. The normal range is 0 to 3 RBCs per high power field. Chest radiograph shows alveolar shadowing spreading from the hilar region, the result of PJM's cytoplasmic staining, antineutrophil cytoplasmic antibody, abbreviated as CANCA, is positive. My first question to you reads, on the basis of his subjective and objective data, which of the chronic glomerulopathies is PJM likely to have? Vagal granulomatosis is a primary systemic vasculitis characterized by granulomatous inflammation of the upper and lower respiratory tract and secondary glomerulonephritis. Primary systemic vasculitic syndromes, such as vagal granulomatosis, often cause glomerulonephritis. Although vasculitis involves inflammation of blood vessels of any size, the small and medium-sized vessels are most commonly affected. The etiology of vagal granulomatosis is unclear. However, an autoimmune response is suspected for 2 reasons. First, Vagina granulomatosis is a systemic inflammatory disease without a known infectious etiology. Second, good treatment response can be obtained with immunosuppressive therapy. The clinical features of vagina granulomatosis include upper airway disease, such as sinusitis, epistaxis, and nasopharyngitis, as well as otitis media caused by blockage of the eustachian tube. Constitutional symptoms include fever, night sweats, arthralgia, anorexia, and malaise. After a few months, weakness may progress, severely limiting physical activity. Although the lungs are invariably affected, most patients remain asymptomatic. However, cough and hemoptysis may be present. Patient PJM's presenting symptoms are consistent with the above clinical features. The laboratory signs also are nonspecific and indicate the presence of a systemic inflammatory process. They include an elevated erythrocyte sedimentation rate in virtually all patients, anemia of chronic disease, and thrombocytosis. Hematuria and proteinuria can be prominent features of vagina granulomatosis and are present on initial presentation in 80% of patients. The presence of severely diminished kidney function, seen in approximately 10% of patients, is an ominous sign, with nearly 1/3 of these patients progressing to end-stage renal disease. All patients with vagina granulomatosis are at risk of developing irreversible, rapidly progressive kidney failure. Kidney histologic findings are nonspecific, with most patients exhibiting necrotizing crescentic glomerulonephritis. Vagina granulomatosis is diagnosed primarily by the presenting signs and symptoms. According to the American College of Rheumatology 1990 classification, a person is diagnosed with vagina granulomatosis if any two of the following four criteria are present. A. Nasal or oral inflammation. B. Abnormal chest radiograph. C. Microhematuria, that is above 5 RBCs per high power field or RBC casts in the urine sediment. Or D. Granulomatous inflammation on biopsy. Patient PJM has satisfied 3 of the 4 criteria for diagnosing vagina granulomatosis. My next question to you reads: how should PJM's vagina granulomatosis be treated? The discovery of cytoplasmic antineutrophil cytoplasmic antibody and its strong association with vagina granulomatosis has permitted a more certain diagnosis. Because of the substantial rise in titer that commonly precedes relapse of vagina granulomatosis, the cytoplasmic antineutrophil cytoplasmic antibody test is best used to follow the course of disease activity and guide induction of therapy. Treatment with cyclophosphamide and corticosteroids results in improvement in kidney function in approximately 80% to 85% of patients, versus 75% with pulse steroids alone. The main predictive factors for treatment success are the extent of kidney damage before therapy starts and how long therapy is delayed after symptoms develop. I will now briefly look at cyclophosphamide. Because vagina granulomatosis is considered an autoimmune inflammatory disease, immunosuppressive therapy is the mainstay of treatment. Therapy is generally indicated for 6 months if remission occurs and up to 12 months in resistant cases. Patient PJM should be started on oral cyclophosphamide 2 mg per kilogram per day, as a single morning dose, and corticosteroids to prevent irreversible glomerular scarring. High fluid intake, that is more than 3 liters per day, and mesna reduce the risk of hemorrhagic cystitis. Regular urinalysis should be performed every 3 to 6 months to detect hematuria caused by hemorrhagic cystitis. Let's now take a closer look at corticosteroids. The main role of corticosteroids is to induce remission of the disease. Patient PJM should receive prednisone dosed at 1 mg per kilogram per day in addition to cyclophosphamide. The combined regimen should be continued for 2 to 4 weeks until the immunosuppressive effect of cyclophosphamide becomes evident. Then, during the next 2 months, the prednisone dose can be tapered to 60 mg every other day to reduce the risk of infection. Then, the dose can be tapered by 5 mg per week to discontinue prednisone over the course of 3 to 6 months. For patients with a more fulminant form of the disease, pulse methylprednisolone 500 mg per day for 3 doses is administered. The dose can be repeated in 1 to 2 weeks if disease progression is uncontrolled. We will now consider alternative therapies. Rituximab as an induction agent has been evaluated in 2 randomized controlled trials. The RITUXVAS randomized 44 subjects to rituximab, dosed at 375 mg per meter squared weekly for 4 doses, plus IV cyclophosphamide or to IV cyclophosphamide alone. Each group received IV methylprednisolone followed by oral corticosteroids. Remission rates were 76% for the rituximab group and 82% for cyclophosphamide. The RAAS trial rituximab was compared to oral cyclophosphamide, 2 mg per kilogram per day, for up to 3 months plus azathioprine dosed at 2 mg per kilogram per day, for 4 to 6 months. IV methylprednisolone plus oral corticosteroid were given to both groups. Rituximab proved non-inferior to the cyclophosphamide regimen with similar rates, 64% versus 53%, respectively. There were no significant differences in adverse events rates in either trial. Although rituximab has performed well in comparison studies, the high cost limits its acceptance and applicability in clinical practice. We will now consider azathioprine and mycophenolate mofetil. Azathioprine dosed at 1 to 2 mg per kilogram per day, and mycophenolate mofetil, dosed at up to 1 gram daily, are effective as maintenance therapy once remission has been achieved with cyclophosphamide. However, a comparative study demonstrated mycophenolate to be less effective at maintaining remissions compared with azathioprine, thus azathioprine is the preferred maintenance therapy. Maintenance therapy should be continued for a minimum of 18 months for patients in complete remission. Next I will briefly talk about alternative agents. Methotrexate may be beneficial for patients with milder disease. Although one study demonstrated high relapse rates in patients treated initially with weekly methotrexate and daily prednisone, disease was controlled in only select patients. However, methotrexate should be reserved for patients intolerant of azathioprine and mycophenolate mofetil and GFR greater than 60 ml per minute per 1.73 meters squared. Use of trimethoprim sulfamethoxazole for 1 year was evaluated for patients in remission or after treatment with cyclophosphamide and prednisolone and is recommended for those with upper respiratory tract disease. A reduction in relapse rate was demonstrated compared with placebo. However, trimethoprim sulfamethoxazole use is not supported. Next I will briefly talk about alternative agents. Methotrexate may be beneficial for patients with milder disease. Although one study demonstrated high relapse rates in patients treated initially with weekly methotrexate and daily prednisone, disease was controlled in only select patients. However, Methotrexate should be reserved for patients intolerant of azathioprine and mycophenolate mofetil and GFR greater than 60 ml per minute per 1.73 meters squared. Use of trimethoprim sulfamethoxazole for 1 year was evaluated for patients in remission or after treatment with cyclophosphamide and prednisolone and is recommended for those with upper respiratory tract disease. A reduction in relapse rate was demonstrated compared with placebo. However, trimethoprim sulfamethoxazole use is not supported. Next, I will briefly talk about alternative agents. Methotrexate may be beneficial for patients with milder disease. Although one study demonstrated high relapse rates in patients treated initially with weekly methotrexate and daily prednisone, disease was controlled in only select patients. However, methotrexate should be reserved for patients intolerant of azathioprine and mycophenolate mofetil and GFR greater than 60 ml per minute per 1.73 meters squared. Use of trimethoprim sulfamethoxazole for 1 year was evaluated for patients in remission or after treatment with cyclophosphamide and prednisolone and is recommended for those with upper respiratory tract disease. A reduction in relapse rate was demonstrated compared with placebo. However, trimethoprim sulfamethoxazole use is not supported. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 519.